Welcome to the Wood Forum 2022 on Healthy Joints for Life. And on behalf of the University of Calgary and the McCaig Institute for Bone and Joint Health, we would like to welcome you, both to those of you who are here joining us in person and to those of you who are participating virtually. My name is Lisa Bose, and it's a pleasure to be your host once again this morning. Just a quick background, I'm a physical education graduate, a broadcaster, and the author of the Lucy Tries Sports children's book series, which inspires our next generation to be active and to persevere. So I'm a big advocate for healthy living, and it's always a great opportunity for me as well to be part of this event. So thank you once again for having me here this morning. I'd like to now take this opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. And the City of Calgary is also home to the Métis Nation of Alberta, Region Number 3. A few housekeeping and technical notes for you. So just for those of us who are here, the washrooms are located just past the coast check out by the main entrance. And if you find yourself that sitting for long periods of time can sometimes be uncomfortable, that we really do encourage you to get up and walk around during the presentation. Use the ramps here to, just give yourself, especially your backs, a little bit of a break to stretch your legs. And for those of you who are watching from home, below the video screen, you can view the event program and learn more about the speakers. And also to the right of the screen, you will notice the Q&A box. And so if you experience any technical issues, please contact Maven Media by clicking the Technical Support tab at the bottom of the video screen. Now, if you have questions during the presentations, feel free to submit them by typing your question in the Q&A box, but the questions will be reserved for the Q&A panel at the end of the program. So you can enter those questions in there, but they won't be answered until near the end of the program. Now, for those of you who are here with us in person, please jot down your questions and save them for the Q&A, and we will have volunteers that will come around with a microphone, and you can ask your question that way. Please note that our speakers they're super happy to answer your questions, but we want to remind you that they will not be able to provide you with specific medical advice. So just general questions, please. And lastly, today's presentations will be recorded, and the recording will be shared on YouTube and the McCaig Institute website after the event. Now, today's Wood Forum is an initiative supported through the Wood Joint Research Fund, created by Dr. John and Christena Wood, that is now carried on by their daughter, Dr. Donna Wood, and in their honor, she has carried this on. Thank you so much, Dr. Wood. And also a warm welcome to Christina's twin sister, Marg Southern, who is joining us here today. Hello, Mrs. Southern. It is so wonderful to see you again. These annual forums are designed to bring the public and researchers together to discuss the impact of bone and joint diseases and injuries and learn about the latest cutting-edge research in these areas. We'd like to thank the Wood family for their ongoing support and leadership with this event. Thank you. Before we get into the program today, I would like to welcome Dr. Stephen Boyd, a researcher and the director of the McCaig Institute for Bone and Joint Health. Dr. Boyd is a professor in the Department of Radiology in the Cummings School of Medicine, with joint appointments in the Schulich School of Engineering and the Faculty of Kinesiology. His research focuses on the adaptive changes in bone that occur following a joint injury or disease. Ladies and gentlemen, those of you at home, please welcome Dr. Stephen Boyd.
Great, thank you very much, Lisa. So welcome to the Wood Forum for 2022. As Lisa said, I'm a professor in the Department of Radiology and director of the McCaig Institute for Bone and Joint Health. For those of you who don't know, the McCaig Institute for Bone and Joint Health is at the University of Calgary and is a team of multidisciplinary researchers coming from all types of background working in the area of bone and joint. So these would be radiologists, orthopedic surgeons, kinesiologists, basic scientists, people like me, biomedical engineers, all working toward finding solutions for bone and joint problems. The major areas that we focus on are diseases, for example, prevention and treatment of diseases like osteoporosis, osteoarthritis, rheumatoid arthritis, and in general, trying to keep our bones and joints healthy. So this is the 10th anniversary of the Wood Forum. And actually, I was thinking a little bit, the last time we held it in this room, I watched Dr. Jim Powell, an orthopedic surgeon, give a demonstration, a physical demonstration, of how to do hip arthroplasty, replace your hip. And so he had some plastic bones, and he sat up here with a hacksaw, and he cut off the end of the bone, showed everybody where he's going to put the implant, put the metal implant into the bone, held up a big hammer, and with a twinkle in his eye, he looked to the audience and he said, "This is where it's really important to be accurate." So it had a big impression on me at the beginning, and there's been many events like this that are a real treat. So I hope you look forward to the Wood Forum today. So on behalf of the McCaig Institute, I'd really like to thank, as Lisa has just done, Dr. Donna Wood and her family for supporting this event for many years and actually playing a role in helping develop the ideas that we present here at the Wood Forum, and for the Wood Joint Research Fund, which her family supports. So with that, I'd like to turn it back to you, Lisa. Thank you.
Thank you, Dr. Boyd. Now, today's event will host 4 presentations from our expert speaker panel who will discuss the latest research advances for maintaining healthy joints. We all rely on our joints to move about our daily lives and do the things that we enjoy, whether it is partaking in a hobby, playing with our kids or our grandkids, exercising, stretching, walking. Our joints are just so important, right, for our daily lives. When our joints are not performing at their best, we sure notice it, don't we? I've had some issues with my back recently. I really can't sit for long periods of time, and it's really annoying. It really is. And we really do notice how they impact us on the things that we love to do. Fortunately, there are people who literally spend their lives, their careers, focusing on how to keep our joints healthy and moving, and we are excited for the opportunity to hear from them today. All right, to open our program, we have first Dr. Raylene Reimer, who will speak about our gut health and its importance in our joint health. Dr. Reimer is a professor and interim dean in the Faculty of Kinesiology at the University of Calgary. She holds a joint appointment in the Department of Biochemistry and Molecular Biology in the Cummings School of Medicine and is a full scientist in the Alberta Children's Hospital Research Institute. She is also a registered dietitian. Dr. Reimer's research focuses on diet and how it can be used to manage chronic diseases like obesity, diabetes, fatty liver disease, and osteoarthritis. She is particularly interested in gut health and how dietary fiber can be used to feed healthy bacteria in the intestine. Dr. Reimer has published nearly 200 papers, and in 2021, she received the Earl Willard McHenry Award for Distinguished Service in Nutrition from the Canadian Nutrition Society. Ladies and gentlemen, please welcome Dr. Raylene Reimer.
Well, good morning, and it's a pleasure to speak today on perhaps a topic and 2 areas of the body that might seem disjointed. Little pun. The gut, or our intestinal tract, and our joints. So I'm going to jump right in and ask you to consider whether you think of bacteria as a friend or as a foe. And in the late 1800s, it was discovered that bacteria can cause infections. And it wasn't until 1928, with the discovery of penicillin, that we actually had an effective way to treat these bacterial infections. And in fact, before we had antibiotics, 90% of children with bacterial meningitis actually died. So antibiotics soon became recognized as life-saving drugs, and their use became widespread. But if we fast forward to about 20 years ago, we started to see some alarming trends emerge. And this was that with increased antibiotic use, we saw it coincided with increased risk or increased incidence of childhood asthma and obesity. And so while the infections were decreasing, chronic diseases were increasing, which led researchers to begin to rethink about our relationship with bacteria. And perhaps bacteria are, in fact, good for our overall health. And so today, we recognize that all of these bacteria and other microorganisms that live in and on our body, and we call these the microbiome, actually have a very important role to play in our health. And if we think about these 40 trillion microorganisms that live with us in our body, the majority of those would be bacteria, and a very large proportion of them would live in our intestine, or what we just call the gut. And so we know these bacteria do many important and beneficial functions or activities for us as the host. And so these can include breaking down dietary fiber. So without bacteria, we wouldn't actually get any benefit from fiber. So they help us get benefit from dietary fiber. They produce some vitamins for us. They train our immune system, which is incredibly important when we are infants. So we are born with a very immature immune system, and it's these bacteria, particularly in our gut, that help to train that immune system to be appropriate in its responses as we grow. It can suppress the growth of pathogenic bacteria, or these bad bacteria that can really cause disease and different conditions in the body, helps with keeping our intestine moving, motility, and intestinal function. And they actually are involved in drug metabolism, so maybe activating a drug so it works in our body, or breaking down and helping to get rid of and eliminate drugs. And interestingly enough, again, very far removed from our gut, it can actually affect our mood. So all of these wonderful bacteria, this community of bacteria, do great things for us. But what we know is that this microbiome, this community of bacteria, can actually become imbalanced as well. And that imbalanced microbiome can lead to disease. And so what we know, I'll just give you an example of how this could actually affect different diseases in the body. So, for example, if we eat a lot of sugary and fatty foods, this can change the types of bacteria that live in our intestine, and they can become altered and imbalanced. And when this happens, the intestinal tract is affected, and so our intestine is actually a barrier between the outside world and what's allowed to get into our bloodstream. And so when the bacteria becomes imbalanced, this nice barrier can actually become leaky. So you may have heard this term, leaky gut. And so what this allows is some particles from the bacteria, or maybe bacteria themselves in some cases, to actually leak through our intestinal cells and get into our bloodstream. And when that happens, those particles from the bacteria can trigger inflammation in the body. And that can go to many distant sites in the body. So it can affect our brain, it could affect our adipose tissue where we store body fat, or the liver, and perhaps also our joints, which we'll focus on today. So if we know that the gut microbiome is really important in health, then the next question really becomes, well, what factors influence what that bacteria, that community, is actually going to look like. And one of the major factors is diet. It has a tremendous impact on what our gut microbiota is going to look like. And of course, we'd like to eat the foods that create this nice relationship between us and the bacteria and promote health in us. And one of the best foods that you can consume to feed your healthy gut microbiome is dietary fiber. So the bacteria love fiber, and the healthy bacteria will flourish on a diet with lots of fiber in it, including whole natural foods as well. But, of course, over the past several years, researchers have also discovered food that can disrupt our or cause an imbalance in our microbiome. So these include, as I've mentioned, sugary and fatty foods. All those things that taste really good can fall sometimes into that category. Artificial sweeteners have been identified. Dietary emulsifiers. So these are additives that are put into foods like ice cream or desserts and make them really nice and creamy, but can also, in higher amounts, disrupt our microbiome. And then something called ultra-processed foods. So if we think about a food in its natural state, say like corn, and manufacturers take that original food and add a lot of ingredients to it, maybe some sugar, some fat, and really change the form of that food into something that's packaged, that would be an ultra-processed food. So in addition to the foods, we also have quite a bit of focus in the recent years on something called the prebiotics and the probiotics. And these are known specifically for their benefits on our gut microbiome. And probably more people are familiar with the term probiotics. So this is when you consume the bacteria, the healthy bacteria, directly. So a lot of people would be familiar with probiotic supplements, so this would be in a capsule form. You can also get probiotics in certain yogurts, where they have added the healthy bacteria. But as well, fermented foods and drinks. So we could think of sauerkraut, or we could think of fermented dairy called kefir. And all of these can provide to us these healthy bacteria. And one of the major questions, that very common question, is, well, which probiotic should I be taking? And that's an excellent question, because they're not all the same, and they don't all have an impact on the same thing. So I won't go into details. We could perhaps talk more in the Q&A session, but the International Scientific Association for Probiotics and Prebiotics have come out every year and updated a clinical guide to probiotic products that are available here in Canada, in our grocery store shelves, our drugstores, health food stores. These are all evaluated according to scientific evidence, and we can go there and look which one might be most appropriate. So if probiotics is eating the bacteria themselves, then prebiotics we can think about as the fertilizer to feed the healthy bacteria that already live in our intestine. So this is the food to feed the healthy bacteria. And we can get this in certain foods, so onions, garlic, artichokes. These would be kind of the foods that would have a natural content of prebiotic fiber in them. But if in your future you don't see days filled with eating onions and garlic, then there is also supplement forms of prebiotics that can be taken, and this is typically in a powder form, and inulin and oligofructose would be two common prebiotics. So let's think about this now in terms of the microbiome and its influence. How might it influence osteoarthritis? So as I mentioned, we can have the intestine become leaky and inflamed. And when that happens, these microbial chemicals or their metabolites that they put out, or the bacterial particles themselves, could get to the joint and trigger inflammation and potentially eventually lead to joint damage. So if we would like to interrupt that cycle, what might that look like? And so my lab has been very interested in our research to look at, could prebiotics, by improving the gut microbiome, maybe have a beneficial effect on the knee joint, which was what our interest was, is knee osteoarthritis. So what we did was test the effect of a prebiotic fiber supplement on physical function and pain in adults who had knee osteoarthritis, as well as an elevated body mass index. And the reason we enrolled participants into our study that had extra weight is because we know that overweight and obesity can be a significant risk factor for osteoarthritis. And so these were adults 30 to 75 years of age. They either had to take, they were randomized to a prebiotic fiber supplement or the sugar pill, the placebo. And for 6 months, they consumed that. And what we were most interested in, our primary outcome that we really wanted to look at, was what is their physical function and does it improve? So we did a number of tests before they started the supplement and after. And I'm just going to very briefly tell you what some of the changes that were seen in those participants. So these are all very relevant for activities we do in daily life. They did a 40-meter fast-paced walk. So how quickly can you walk on this loop that we had there? Another one, can you get up out of a chair and walk 3 meters and turn around and come back, sit down? And how fast can you do that? Another one is a hand grip strength test. So squeeze as hard as you can on that instrument there, and we can test how strong your grip strength is. And another one, we just asked them, okay, you have 6 minutes, just go out and walk as far as you can in those 6 minutes. And so we measured that before and after the supplement, and with the prebiotic supplement, we saw within those participants an improvement in all of those factors. And probably most important to the participants was they also reported that had a reduction in pain as well. So to conclude, I would like to say that this is a new area of research. There's likely to be more applications for osteoarthritis to come. I think it's very important that we don't want to overpromise. So it's a supplement, those improvements we saw in physical function were meaningful, but it didn't completely restore them to a young, healthy individuals. So we don't want to overpromise, but we think there's some great potential that might come out of this area of research, or linking the gut to our joints. And my take-home message for you is, for all of us, irregardless of our age, is to eat more microbiome-friendly foods. So more fiber-rich foods. Some examples could be apples, more broccoli, berries are a fantastic source of fiber for us. And then maybe concentrate specifically on foods that have prebiotic fiber, the unique type of fiber. So onions, asparagus, artichokes are all very good there. And then more fermented foods. So we need to get more bacterial back into our body. We've over-sterilized a lot of things, so yogurt, sauerkraut, kefir. And I will leave you with my favorite saying, healthy gut, healthy life. And perhaps, as the research goes, we could maybe add to that healthy gut, healthy knees, and maybe healthy gut, healthy hips. So maybe that will catch on one day. So thank you very much.
So, thank you, Dr. Reimer. Amazing, right? I don't know about you, but I'm planning our meals now definitely a lot differently than I did before that. Thank you for those tips. This is the beautiful thing about the Wood Forum, is how much we absorb so much. I learned so much from these forums that I love to take away to my professional and personal life. And I will also be mentioning to my husband, who I did notice in our pantry, he loves his chips. And so I will be mentioning a few things about those Doritos that I saw the other night. Okay, thank you, Dr. Reimer. And I hope some of you have been jotting down some questions for our Q&A because there was so much good stuff in there, especially about what we need with that fiber-rich foods that we need to keep our joints healthy, the rest of our body healthy. Okay, next I would like to introduce Dr. Jason Werle, who will discuss treatment options for osteoarthritis and ways to help you feel empowered in your healthcare journey. Dr. Werle is the Senior Medical Director of the Bone and Joint Health Strategic Clinical Network and the Chief Section of Orthopedic Surgery, University of Calgary. He's also the President of the Canadian Arthroplasty Society and a McCaig Institute member. Dr. Werle grew up on a farm near Langenburg, Saskatchewan, and believes that the upbringing that he had really taught him the importance of hard work and a sense of optimism for the future. He stayed close to home to earn his Doctor of Medicine from the University of Saskatchewan, later traveling farther afield to complete a fellowship at Stanford University in California. His current orthopedic surgery practice is focused on joint replacements and single limb trauma surgery. Ladies and gentlemen, those of you at home, please welcome Dr. Werle.
Thank you, Lisa, and thank you to the Wood family for this opportunity to speak to you today. The title of my talk is Ouch, enter your joint name, so you could put hip, knee, shoulder, base of your thumb hurts, 9 steps that can help you. So I'm an orthopedic surgeon at Rocky View Hospital. I spend my OR days replacing knees and hips, so I certainly identify with the glint in your eye when I have a hammer in my hand that Dr. Boyd was mentioning at the early part. It's a successful operation. It changes people's quality of life, eliminates pain in the vast majority of cases, and it really has good results. But really, I'm here to talk to you about patients that don't need joint replacement. This is the osteoarthritis treatment pyramid, and it's from an article by Eva Roos, who developed the GLAD program. And what it demonstrates is that surgery is really just for a small portion of patients that have osteoarthritis. There's lots of other treatments, including education, exercise, weight control, and other medical treatments that can be used prior to someone actually needing a joint replacement. And some don't ever go on to require a hip or a knee replacement. It's a big problem. 1 in 8 Albertans has osteoarthritis of the hip or knee or other joints. It's more than 500,000 people in our province. And about 40% of visits to family doctors are related to musculoskeletal problems, and the majority are for osteoarthritis. There is a gap in care. We know about 20,000 people with osteoarthritis of the hip or knee are referred to an orthopedic surgeon in Alberta each year, but half of them don't require surgery and are considered non-surgical. And unfortunately, to date, there hasn't been unified guidance for Albertans, for practitioners, or for patients to help navigate evidence-based non-surgical OA treatments. So to address this gap in care, a clinical committee was developed by our Strategic Clinical Network. A multidisciplinary team of OA experts came together from across the province beginning in January 2019. And the purpose was to provide an independent review and set standards for the best possible care for individuals that are living with osteoarthritis. And the first project was to design clinical practice guidelines to support people with OA throughout their journey with the disease. This is the infographic of what was developed, and we'll go through the 9 different steps in more detail in the slides that are upcoming. But it's important to note that individual preferences, values, goals, and individual quality of life was incorporated into the planning for these quality care standards. The purpose of the standards is to help patients and their families understand the best care options for managing hip and knee osteoarthritis in Alberta, to guide clinicians on the best practices for osteoarthritis care based on strong published literature and also expert consensus, and to provide healthcare organizations like Alberta Health and Alberta Health Services with tools to measure, analyze, and improve the quality of care for people with hip or knee osteoarthritis. So we'll just briefly touch on the 9 steps. Step 1 is to get assessed for osteoarthritis, and this can be done by a variety of clinicians. There are family physicians, there's physiotherapists, athletic therapists, chiropractors, kinesiologists, many people who are trained in the diagnosis of osteoarthritis. And at most, you need a plain x-ray, and it's illustrated in the bottom of the slide, where you can see the difference between a healthy knee, where there's still a joint space and cartilage present, versus an arthritic knee, where that joint space is gone and it's bone on bone. I put an MRI scanner picture on the left-hand bottom side of the slide, just to remind you, you do not need an MRI to diagnose osteoarthritis. And Dr. Walker, an expert radiologist, is going to talk to you more about that in one of the upcoming talks. The second step is to develop a care plan with your provider, regardless of who that provider is, whether it's a physiotherapist or your family physician. Having regular check-ins on your care plan would be important. The third step is to tailor treatments over time. Osteoarthritis is a chronic disease, and treatments will change over time. There are many, many treatments in the osteoarthritis toolbox. The core treatments being education, exercise, and physical activity and weight management, but there are also adjunct treatments, such as non-pharmacological and pharmacological treatments. Step 4 is to get educated. And we're fortunate to have many resources locally and provincially as well as online. The Arthritis Society and myhealthalberta.ca are very good online resources and organizations to help learn more about osteoarthritis. There's also the GLAD program offered in physiotherapy clinics around the province, and then the University of Calgary Joint Effort Program, Alberta Healthy Living, and also your family physician and physiotherapists can help. Step 5 is exercise. It is a myth that one shouldn't exercise because it could cause more damage to your joint when you have osteoarthritis. Abundant global literature indicates that you should continue to do low-impact exercise to help, generally from your overall health, your mental health, your cardiovascular health, as well as your joints. The target is 150 minutes per week of moderate or vigorous aerobic activity, and it's low-impact activity. So that's 30 minutes 5 times a week. I would recommend walking, aquasize, or cycling. Step 6 is to manage your weight, and that's core treatment 3. And it's important to know, because of the biomechanics of the hip or the knee, that every little bit helps. So every pound lost is about 4 to 6 pounds across the knee or the hip. And it's important to keep those goals in mind. Why is it important? Well, if you do happen to fail conservative treatment and go on to surgery for a joint replacement, there is a drastic difference in outcomes when people are overweight versus not overweight. This is Alberta-based data from the Alberta Bone and Joint Health Institute on patients, Albertans, that have had joint replacements. And the risk of an early revision, a failure of their joint replacement, is almost double in patients that have a body mass index greater than 30 versus below 30. The odds of a medical adverse event like a heart attack or stroke around the time of surgery is 1.38 times higher for obese patients versus non-obese patients. The odds of a pulmonary embolism, a blood clot that goes to the lungs, is 1.5 times higher. And the odds of a deep infection are 3.6 times higher in people that have a BMI over 30 versus under 30. There are many additional treatments, adjunct treatments, that can be added. Some of them are medicines, some of them are non-medicines. Some of them are bracing. You could use a cane. There are cognitive and behavioral therapy sessions or interdisciplinary self-management programs. And then there's the pharmacological treatments as well. Many of you are familiar with these, like Tylenol for arthritis, which has a large safety profile and can be taken regularly. Sometimes prescription medications are required, like anti-inflammatories. Opioids really don't have a role in the treatment of osteoarthritis and are not recommended. And then occasionally intra-articular injections, like the use of cortisone or hyaluronic acid, such as Synvisc or Durlane, can be used to treat people's symptoms. Step 8 is to get referred for joint surgery if you fail conservative treatments. We're very fortunate to live in Alberta. We have the Alberta Surgical Initiative, and although the pandemic has impacted wait times, this initiative is going to continue forward, and hopefully with the new Premier, it's going to continue forward. There are 5 strategies. The overall goal is to reduce wait times for people waiting for surgery, and that includes orthopedic surgery and hip and knee replacements. And one component of the Alberta Surgical Initiative is the Facilitated Access to Specialized Treatment, or the FAST program, which is being implemented as we speak province-wide and is a central intake and triage system to ensure that patients see the right provider at the right time in the quickest possible time. And then step 9 is to measure quality of care. Again, we're fortunate. We have the McCaig Institute for Bone and Joint Health and the Mobility for Life program. There's also the Bone and Joint Health Strategic Clinical Network. I'm the medical director for that. There's the Alberta Bone and Joint Health Institute and their MAP to Motion program. And all of these entities are providing research, and I encourage all of you, if you're handed a questionnaire or a survey, to complete it, because it will help improve the quality of your care in the future, and it will help with other patients that are undergoing treatments for osteoarthritis. As well, we send data from Alberta to the Canadian Institute for Health Information. Every patient that gets a joint replacement in the province of Alberta has data sent to the Canadian Joint Replacement Registry, so we monitor the performance of these joint replacements. And then our clinical information system across Alberta within Alberta Health Services is called Connect Care, and that's being implemented. So regardless of where you receive care in the health system, it can be identified, and there'll be continuity of care. So if you want to access these standards, we have some postcards on some tables at the back during the session afterwards. We'll have this website and the links, and so there's full standards, there's a one-pager summary and reference guides. I encourage you to use these resources. This is what it looks like when you go online, so you can navigate yourself through the website. In summary, osteoarthritis is a chronic disease. Symptoms will wax and wane over time. There are many tools in the OA toolbox. Education, exercise, and weight management are core treatments, and evidence-based non-pharmacological and pharmacological adjuncts can help. Surgery is a good option when conservative treatments fail, and measurement is the key to improving our healthcare system. Thank you.
Thank you. Thank you. Thank you, Dr. Werle. Isn't it so wonderful to learn all these resources that we have here in Alberta, and people like Dr. Werle to help us navigate that and to get through that. I know in my stage of life, I'm headed to another bone density. I'm one of those that's at, I guess that's the stage before osteoarthritis, so I feel lucky to know. I mean, I may be facing that, but I'm going to do my darndest to try to prevent it as best I can, especially with my family history. Anyway, enough about that. Thank you so much, though, for that, Dr. Werle. And now I would like to invite Dr. Richard Walker to share with you his insights about when imaging may or may not be required. I think this will be extremely interesting as well. Dr. Walker is an associate professor in the Department of Radiology and is a member of the McCaig Institute for Bone and Joint Health. After graduating and completing residency training in family medicine, he practiced primary care in northern Saskatchewan for a couple of years, and then following that, he completed residency training in diagnostic radiology at Boston University School of Medicine. His primary research interests include multimodal imaging of sports-related injuries and joint trauma, imaging appropriateness, and quality improvement. Dr. Walker spent 5 years as clinical and academic head of radiology at the University of Calgary and has consulted for not only the World Junior Hockey Championships, but volunteered at the Vancouver Winter Olympic and Paralympic Games as a radiologist. Ladies and gentlemen, please welcome Dr. Walker.
Thank you for that kind introduction. It's really wonderful to be here and to present to you the title of my talk, MRY, Be Imaging Informed. And I have no relevant disclosures. Sorry, it's a habit. In 2010, the fellows and members of the Royal College of Physicians and Surgeons of Edinburgh voted on what the top 20 most important medical developments were in the last 50 years. I don't think anyone would be surprised to see antibiotics at number 1 or perhaps vaccinations at number 2, but I bet many are surprised to see imaging at number 3. And the caption reads, "The development of CT and MRI scanning has revolutionized the manner in which the body can be scanned in order to detect disease and inform treatment and a range of disease areas. And it's absolutely true. Computed tomography, or what we refer to as CT, or magnetic resonance imaging, or MRI, has had a profound impact on healthcare and medicine. Here are two examples of the exquisite detail that you can see with modern imaging. On the right side here, this is a micro CT scan of a study knee participant who has an ACL tear. This was performed at the McCaig Institute. And the resolution on this is 63 micrometers, which is only slightly thicker than a human hair. On the other side, this is a complete spine MRI in a patient with inflammatory back pain or ankylosing spondylitis. And as shown here in the red ovals, there is inflammation in the spine as well as by the curved arrows at the interspinous ligaments. And it's important because MRI has such ability to pick up detail that we can see inflammation that will not be visible on radiographs. And it's very important in the management of these people with this disease. So MRI, why? When should an MRI be performed? And when is an MRI likely not required? So we'll talk about over the next 12 minutes. So a few facts about knee osteoarthritis. It affects a lot of people, 240 million persons worldwide, and the hip and the knee are the most commonly affected joints. Symptoms include pain and stiffness, often worse in the morning or after prolonged sitting. Typically will start to improve after some activity in 30 minutes. The diagnosis, the provisional diagnosis, can almost always be made on history and physical exam, and it's an X-ray that is the imaging modality of choice for the assessment of osteoarthritis, usually confirming the diagnosis and also giving us impression of the severity of the damage of the knee. Now, it's important to note that the X-rays do not always correlate with the severity that we see or that a patient experiences. So it might be that someone has very severe looking X-rays and bad arthritis on their X-rays, but actually they don't have many symptoms. And the corollary is true as well, that people may have quite severe symptoms, yet not severe X-ray changes. One thing that is a quote directly from this article by Katz that was published in the Journal of the American Medical Association, magnetic resonance imaging is seldom indicated in the assessment or management of knee or hip osteoarthritis. So I'll speak a little bit, twice I'll comment about Choosing Wisely Canada. Now, Choosing Wisely Canada is a campaign that encourages informed discussions between patients and clinicians or primary care providers around tests, around treatments, and around procedures related to their health. And in 2018, the Canadian Orthopedic Association released 5 new recommendations. And interesting, the first 2 were related to osteoarthritis of the knee. The first, don't use arthroscopic debridement as a primary treatment in the management of osteoarthritis of the knee. The second, don't order a knee MRI when weight-bearing X-rays demonstrate osteoarthritis and symptoms are suggestive of osteoarthritis, as the MRI rarely adds useful information to guide diagnosis and treatment. So let's look at that a little bit further. So here, similar to what Jason showed, this is a normal X-ray on the right, and this is an osteoarthritic X-ray on the left. Or pardon me, on the right, osteoarthritis, on the left, a normal X-ray. So the question, my knee hurts, it could be osteoarthritis. Do I need an MRI? Well, if your knee hurts and this is your X-rays, it might be reasonable to perform an MRI to look for a soft tissue abnormality that's causing your problems. However, if your knee looks like this, which demonstrates severe medial compartment osteoarthritis, worse on the left, and if your symptoms are in the medial aspect of your knee or the inner part of your knee and are consistent with osteoarthritis, I would say an X-ray, or pardon me, an MRI is not indicated. Now here's an example of a normal MRI of the knee on the left and an osteoarthritic knee on the right. And if we look at these circles, this is what the knee meniscus looks like, this triangle here, but you can see in the osteoarthritis knee, it's abnormal. It's actually been pushed out of the joint because of the arthritis. And it's interesting that that is probably not what's causing the patient's symptoms in this example. What a lot of researchers feel is that the osteoarthritis pain relates to these changes, which is edema or swelling in the joint. We call them bone marrow lesions that cause the symptoms in osteoarthritis. So what would be the drawback of having an MRI of your knee ordered by a primary care provider if you had moderate to severe osteoarthritis? Well, the first might be that while you're waiting for that MRI, it may delay implementation of effective treatment strategies. And Jason spoke about many of the effective strategies: anti-inflammatory medications, strength exercises, weight modification, if that's appropriate, non-surgical interventions, which might include bracing, or even a surgical assessment and maybe a knee replacement. Second, meniscal tears are common and may not account for knee symptoms, as I showed you previously. And we've shown from the Canadian Orthopedic Association that they do not recommend arthroscopy and debridement in these cases. And finally, the sensation of instability, or that your knee is giving way. Many people may think that relates to a tear of a ligament within their knee, but often in the setting of osteoarthritis, it relates to weak quadriceps. So I'm going to change gears a little bit and now speak a little bit about back pain. It'd be no surprise to anyone here that back pain is common, and about 3/4 of the people in this room will experience an episode of back pain at some point in their lifetime. It's interesting, the risk factors for back pain or low back pain are quite poorly understood. We know that physical work, frequent bending, twisting, or pulling can sometimes be associated with back pain. We also know that there are psychosocial risk factors, including stress and anxiety, that correspond also or participate in low back pain. It turns out there's a lack of correlation in patients' symptoms and MR findings in back pain. So this was a very nice study. It was out of the Seattle area, and they got almost 150 people, and these people had no back pain. And they did an MRI on them, and then every 4 months, someone would call them and ask them specific questions of whether they had back pain. And then at the end of 3 years, they did another MRI. And interestingly, when they looked at those people over that 3-year span, many of them would develop back pain during that time, but if you looked at their MRI before and their MRI after, most of the time it had not changed. They still had some of the changes that they had before when they had no pain. So lack of correlation between patient symptoms and MRI findings. Finally, it's been quite well shown in the literature that acute low back pain is usually self-limited. There's a guideline from the European Guidelines on Primary Care that states 90% of people will recover within the first 6 weeks. There was a meta-analysis that was published in 2012 in the Canadian Medical Association Journal, and it stated that the typical course of back pain is favorable. And so I think a general statement that would be true would be that the majority of people with nonspecific low back pain will recover within the first 6 weeks. So I spoke about choosing wisely earlier. So the Canadian Association of Radiologists and the College of Family Physicians and Surgeons actually share a recommendation within choosing wisely. And it states, don't do imaging of lower back pain in the first 6 weeks unless red flags are present. So what are red flags? Well, red flags are clinical symptoms or signs that could indicate serious disease. They might indicate the need to see a surgeon or even the need to have a surgical procedure performed on your back. So what are red flags? Well, signs that might indicate a compression fracture, signs that might suggest that there's a risk that this could be cancer, which in the published literature is probably about 1% or less of people presenting with low back pain. A spinal infection is very rare, and I showed you previously an example of inflammatory back pain or spinal arthritis that can also cause back pain. Now, this is an example of what spinal infection looks like on an MRI. So on these T1 weighted images, there's edema within the spine and there's loss of the joint space, but if you look here, this is after they've injected contrast, and the whole vertebral bodies, the L1 and the L2 vertebral bodies, enhanced because of infection and inflammation in those joints. So I'm going to conclude by a little bit of a clinical vignette. It was the COVID-19 pandemic. This individual, like many during COVID-19, had put on a bit of weight. We called it the COVID-19. And they were trying to get back into shape, and so they were in their home gym doing some pull-ups, and they had a sudden onset of neck pain and left arm tingling and numbness, so sensory symptoms in the left arm. They tried conservative management for almost 4 to 5 months. They did non-steroidal anti-inflammatory medications, physiotherapy, and despite that, their symptoms did not improve. And in fact, one day, when trying to lift their work bag into the back of their trunk, they realized that they had lost the strength of their arm. They could not lift their bag. And that's actually when I realized that my symptoms were probably not going to get better and that I needed to do something different. So I saw a neurologist. I ended up having an MRI, and this is a picture of that MRI. And so these are the white arrows here point to this disc herniation that's compressing my C5 nerve root, which would make sense when I've got arm weakness and numbness. This is what the normal neuroforamen would look like. I saw a surgeon and ended up having a discectomy and a disc replacement in my spine. Now, I'll confess, I don't usually tell 100 or 150 people about my medical story. But I think it's important to know that as someone who reads MRI for a living and understands the detail that MRI can see, I followed the guidelines. I knew that in the majority of the cases I was going to improve, and I gave it time to improve. I did what I could, but when my symptoms didn't get better or when they got worse, that's when I got referred on to see a specialist and had an MRI. So in summary, question, my knee hurts. It could be osteoarthritis. Do I need an MRI? My recommendation would be get a standing X-ray of the knee, And if that X-ray shows moderate to severe osteoarthritis, an MRI is very unlikely to add benefit to your management and is not indicated. The next question, I hurt my back. Do I need an MRI? There, the recommendation is, well, that depends. But I will say that an MRI is likely not indicated if the duration of your symptoms is less than 6 weeks, when there are no red flags, and on history or suspicious findings on clinical examination. So thank you for your attention.
Thank you, Dr. Walker. Thank you for sharing your personal story with us. We really appreciate it. And there really are so many questions that we need to ask when considering an MRI, which you really clearly defined. So thank you so much. Choose Wisely Canada, another great resource. And finally, I'm pleased to introduce Dr. Jackie Whittaker to you to speak about practical strategies that you can use to keep your knee healthy and prevent osteoarthritis if you have had an injury. Dr. Whittaker is an associate professor in the Department of Physical Therapy at the University of British Columbia and research scientist at Arthritis Research Canada in Vancouver. She has a Michael Smith Foundation for Health Research Scholar Award and Arthritis Society's STARS Career Development Award. As a recognized clinical specialist in rehabilitation, her research takes a lifespan approach to preventing osteoarthritis and is done in conjunction with patients, health professionals, and other stakeholders to make it more relevant to real-world settings. Please welcome Dr. Whittaker.
Thanks. Thanks, Lisa, and thanks to the McKay Institute for this wonderful opportunity. I will say I am not an outsider. I was born and raised in Alberta in a little town called Stettler. I have moved to the West Coast, but I do consider myself still an Albertan. So I'm really excited to be here to talk to you about a topic that's near and dear to my heart, which is knee health. And I suspect for most of us, our knee health isn't something that we think about very much. We don't really, we just take it for granted. Until, of course, something goes wrong and we realize just how important our knees are for doing the things that we have to do or that we need to do. So I'm just wondering, just by a show of hands, and for those of you online, I'm sorry I can't see you, but how many of you have had a knee injury that's interfered with your ability to work or do the things that you want to do? So for everyone online, there's a fair number of hands going up in the crowd, and that's not really surprising because we know knee injuries are incredibly common. They typically occur, believe it or not, between the ages of 15 and 35, and particularly when we're participating in sport and recreational activities. But that's not to say that they can't occur outside of that age range or in other settings. That's just where we see the bulk of them. It has actually been estimated that about 500,000 Canadian youth hurt their knee every year playing sports. And although we'd like to think that those injuries just heal themselves and go away, we know that about half of them will go on to develop osteoarthritis. So that's quite a large number of young people. Now, we've heard a little bit already this morning about osteoarthritis, but I just wanted to make sure we were all on the same page. Osteoarthritis is a degenerative joint disease, and it results in the deterioration of the cartilage, which is that tissue that covers the ends of our bones in our joints. And that can lead to swelling in the joint, pain in the joint, and weakness of the muscles around the joint, which ultimately makes it difficult for people that are living with osteoarthritis to do the things that they love to do. As we heard, I think it was Dr. Werle said, there's a lot of joints that can be affected by osteoarthritis, but the one where we see the majority of the cases, 80% of the cases, is the knee. Now, it's incredibly important to stress that osteoarthritis is a disease. It is not a natural consequence of aging. Not everyone in this room is going to get it. And it's not just normal wear and tear of the joint. And the reason that it's important to understand that it's a disease process, is because just like, I don't know, diabetes or cardiovascular disease, once you know you're at increased risks, there's steps that you can take to reduce your risk. But if you think it's inevitable, you're unlikely to do that. And one of the main ways in which our risk for osteoarthritis goes up is when we have a joint injury or when we have a knee injury. And the sort of rotten thing about it is that once you've had a knee injury, the risk doesn't just go away spontaneously on its own. You actually have to live with it for the rest of your life, and you have to learn how to navigate that. Now, that's not necessarily bad news. It's just your new reality. The good news, the silver lining, if there is one, is that the earlier you know that you're at risk, the earlier you can do something about it. And figuring out what to do about it is what my team and myself have been working on for several years now. And what we've learned really is that if you want to reduce your risk for osteoarthritis, there's basically 4 things that you need to be doing. Monitoring your knee so you can act early, feeding your cartilage, building your muscles, and controlling your body weight. So let's start with monitoring your knee. I think we can all appreciate that if you have a knee injury, there's pain, and that pain can interfere with school, work, recreational activities, whatever it is that you're doing. Now, for some people, that pain's going to go away. For other people, it's going to go away, but then it's going to kind of come back. And for other people, it's never really going to go away, and they're going to kind of go down this road of this sort of decline in health, this spiral of health that you can see up on the screen. This spiral, this downward spiral in health is actually quite common, but we don't talk about it a lot. And that's really unfortunate because you can imagine that by the time you've gained weight and you've developed osteoarthritis, it's really hard to reverse things. But if you can act early, maybe when a flare-up hasn't resolved or when you first start to notice that your lifestyle is really changing and you're becoming less physically active, then there's ways that you can actually reduce that from happening. I can't tell you how many people that I have met over my career that went down this downward spiral of health because they just didn't ask for help early enough. I cannot stress strongly enough how important it is to seek help early when you notice that you're becoming inactive. Not wait, thinking, oh, I'll rest my knee, it'll settle itself down, and then I'll be active again, only to wake up a year or two later and realize that your lifestyle has dramatically changed and you're way less active than you used to be. I want to assure you that it is possible to exercise and be active after you've had a knee injury, even if you have flare-ups, and even if you go on to develop osteoarthritis. And in fact, that exercise is the first line of defense against osteoarthritis. And you might ask, well, why is exercise the first line of defense? And it's basically because it comes down to the thing that feeds your cartilage, builds your muscles, and help you control your body weight. So what do I mean by feed your cartilage? Well, remember we mentioned earlier that cartilage is the tissue where we think osteoarthritis starts. And cartilage is sort of a unique tissue. It doesn't have a great blood supply, so it can't get its food the way that most of the tissues in our bodies do. Instead, the way that it works is cartilage acts a little bit like a firm sponge. It's got a bunch of little holes or pores. And just like a sponge, when you squeeze it, you push the fluid out. And the fluid in the joint is actually really important because that's where the food sits that the cartilage needs. So you squish the cartilage, any fluid from the joint that was in it goes out into the joint capsule, and then when you release that squishing, the fluid can come back into the cartilage. So you squeeze, the fluid goes out, you release, the fluid comes back in, bringing with it the food that the cartilage needs to stay healthy. So how do you think we naturally squeeze and unsqueeze our cartilage or compress and uncompress our cartilage to pump that fluid in and out? Pretty safe guess, it's exercise. But it's not just any exercises, it's special exercises. And we call these cyclical weight-bearing exercises, which in all honesty is just a really fancy way to say exercises where we cycle between squishing and unsquishing the cartilage. So loading and unloading the cartilage, compressing it or decompressing the cartilage. Examples of cyclical weight-bearing exercises, they're not fancy. It's walking, it's running, it's jumping, it's climbing stairs, it's squatting. If we don't do these things on a regular basis, our cartilage gets hungry, it gets weak, and it starts to break down. But if we can do a little bit of these exercises every day, we can feed our cartilage and we can give it a fighting chance. Now, I know that that might seem contrary to something you've heard before. A lot of people, including a lot of healthcare practitioners, believe that impact activities and weight-bearing activities aren't good for our joints or for our knees. But what we all need to realize is that cartilage has one job. The reason it is in our joints is to deal with load. It is built to deal with load. And when we take that job away, it becomes weak and it starts to break down. Now, that doesn't mean that after you leave here today, you're going to go home and you're just going to start doing a ton of impact activities. You've got to slowly build your capacity up over a period of time, and you ultimately have to figure out what works best for you. The main message is to know that they're important activities, and if you don't know where to start or you get stuck, you need to reach out to somebody who can help you, and that's likely going to be a healthcare professional that specializes in exercise, like a physiotherapist. Okay, so what about building our muscles? The most important muscles for helping to reduce our risk for knee osteoarthritis are our thigh muscles, so our quadriceps and our hamstrings, our calf muscles, and our glutes, or our butt muscles. And so how do we build muscles? Well, again, it's not a surprise, it's through exercise. But just like medication, if you want exercise to work, then you need an adequate dose. One that's going to be sufficient to stimulate the muscle to grow, to change, to adapt. And that means we have to think about the amount of exercise, how frequently we do it, and for how long or the duration of the exercise. So we have to think about the dose of the exercise. And you might be asking yourself, well, how do I know if I have the right dose? Like, what's the right dose? And the challenging thing is that the right dose is individual. It's not the same for everybody, it's individual. And it takes a little bit of trial and error to figure it out for yourself. And ultimately, it depends on where you're starting from, where you'd like to go, and it's always going to be a balance between these two things, effort and pain. First and foremost, if you don't have enough effort, if there isn't a big enough dose, the muscle will not be stimulated to grow, and you're wasting your time. And one of the biggest mistakes that people make with their exercise is they underdose because they're scared. It's okay. It's not like you're doing it on purpose. There's a few things that you can sort of consider if you want to know, did I do enough? Did I have an adequate dose? The simplest thing is that your muscles should feel fatigued and you should feel shaky after you've exercised. And you probably should have a little bit of second-day soreness, although that might change over time. If you want to get a little bit fancier, you can think about, well, how hard was the exercise on a scale from 1 to 10, and aim for sort of a 7, 8, or 9. And if you're doing an exercise that's a certain number of sets and reps, like 3 sets of 10, when you're done those exercises, you should only have 1 to 3 reps left in the tank before you would be fully fatigued. And if you're not going that far, you're probably not getting enough exercise. Now, the question, though, is how do you balance that with pain, right? How do you do that without increasing pain or having pain? And in all honesty, you might not be able to. But actually, research has shown that it is okay to exercise with pain, as long as that pain is a 5 out of 10 or less, and if it goes up during or after exercise, it comes back to pre-exercise levels within 24 hours. And in fact, if you do exercise with pain and follow those 2 rules, what you will find is over time, your knee pain will decrease. In fact, exercise is one of the most potent painkillers for knee pain, and that's been shown over and over in the research. More effective than education or Tylenol or Advil or ibuprofen or anything else that's up on that screen. I know it seems a little counterintuitive, but there's really good evidence to support that. But again, it doesn't mean that, after today you're going to go home and you're just going to start going crazy with your exercises. You've got to respect where you are, and you gradually have to build up your capacity to do strengthening exercises to build your muscles over time. The big thing is that if you don't know where to start or you're getting stuck, don't give up, don't give in, go out and seek some help. Okay, the last important thing that you need to do to try to reduce your risk for knee osteoarthritis is to control your body weight. And the reason for that is that just like a joint injury, obesity is a very well-established risk factor for osteoarthritis. So if you have a knee injury and you gain a bunch of weight, your risk for osteoarthritis is greater than if you just had the knee injury. I think we can all agree that losing weight is a challenge at the best of times, so it makes a lot more sense to try to prevent the weight gain than lose it. But either way, the best way to control your weight, nobody's going to be shocked by this, is a combination of physical activity and diet. Every country has its own physical activity guidelines, and we've already had ours shared with us a little bit today. In Canada, basically adults should be getting at least 150 minutes, a minimum of 150 minutes of moderate to vigorous physical activity every week. And just so that we're all on the same page, moderate to vigorous means you're sweating when you're doing it. And if you're younger, that should be about 60 minutes a day for up to about 420 minutes per week. As far as diet, again, we can look to the Canadian Dietary Guidelines, which recommend that we eat a variety of healthy foods. Half of our diet should be vegetables and fruits, 25% whole grains, and maybe it'll have some of that dietary fiber that Dr. Reimer was speaking to us about, 25% lean proteins, and our choice of drink should be water over fruity drinks and sugary drinks. Guidelines also encourage us to be mindful of our eating, to try to eat at home a bit more, and to try to limit our intake of those highly processed foods that have a lot of sodium and sugar and saturated fats in them, just as we've heard earlier. So these 4 strategies, simple strategies, can go a long way to improving the health of your knee and reducing your risk for knee osteoarthritis. By monitoring your knee, you can act early at the first signs, particularly the first signs of becoming physically inactive. By doing a little bit of cyclical weight-bearing activity, you can give your cartilage a fighting chance. By doing exercises that build your muscles and physical activity, as well as being mindful of your diet, you can create a healthy environment for your knee. So I'm going to leave you with a couple last few points. If you've had a knee injury, I would encourage you to remember that osteoarthritis is not inevitable, and that the earlier in life you do something about it, the better, as opposed to waiting. Remember to reach out for help early, particularly at the first signs that you think your lifestyle is changing and you're becoming less physically active, so that you can avoid that downward spiral in health. Try to increase your capacity for weight-bearing activity so you can feed your cartilage and keep it healthy. Remember, it's okay to exercise when you have some pain, as long as it's less than a 5 out of 10 and it goes back to pre-exercise levels within 24 hours. And then finally, remember that it's harder to lose weight than it is to prevent the weight gain, and be mindful about the amount of moderate to vigorous physical activity you're getting, as well as your diet. So I'm going to leave you with that, and I think we get some questions now.
Thank you, Dr. Whittaker. Thank you, Dr. Whittaker. Some wonderful takeaways, again, from all of our experts. So now is our chance to mine these minds, if you will. And so I'll ask all of our guest presenters to come back up on stage for our panel discussion. And again, we'd like to encourage you to join the discussion and ask some questions of our experts. Again, they're happy to field any general questions that you might have. But again, we want to reiterate that they are unable to offer specific personal medical advice. So for those of us that are here, if you just want to put up your hand, and one of our student volunteers will come by with the microphone and ask the question. For our virtual participants, we have a volunteer in the audience who will relay your questions as well. And I'm just going to actually start just quickly, because we just heard Dr. Whittaker, and with the knee injuries, I was thinking, is there like some that are worse than others that lead to osteoarthritis when it comes to those injuries?
Yeah, there definitely are, and I don't want to get into the anatomy too much, but if you have a fracture that involves the joint, that's a big risk factor for osteoarthritis. If you tear one of the main ligaments in the middle of your knee, called your anterior cruciate ligament, it's also a big risk factor, particularly if it's combined with a tear of your meniscus. And then if you do something that sort of impacts the cartilage, the covering of the bone, and you get a lesion or a defect, those three are probably the three injuries that are associated with the highest risk of
Okay,
osteoarthritis.
yes, ACLs
are a pandemic, and we've
Aren't
probably
they?
sadly all heard about that. Yeah.
Yes, and especially in youth sports. Okay, I guess we'll take one from, yes, let's go, we'll start in-house, as it were, and then we'll hope to take a question from our virtual audience.
Hi. My question is in regards to the fermented foods. Are there milk alternatives to yogurt and, is it kefir or kefir?
Yes, so we do have an increasing number of plant-based options. So dairy, traditionally, lots of milk products, yogurt obviously made from cow's milk, but there are starting to be some options from plant proteins. So you might, if you go into the dairy section, that's where they'll be found, and you could find some options that are, it's a small component still, but there are some options for those who cannot or maybe don't want to consume the dairy, the fermented dairy. Yeah.
Okay, another from our, Terry, do you have one from our virtual audience?
I do. Thank
Excellent.
you so much to all the presenters. We have a very engaged online audience, so I'm going to relay a couple of questions to you. First, a little bit about some finger joints. So, is finger pain in the morning likely arthritis? And further to that, can fingers that are crooked from arthritis be made straight with physiotherapy or other treatment?
Dr. Werle.
Yeah, so the small joints of the hand are commonly affected with osteoarthritis. People can develop little bumps called Heberden's nodes, which are just bone spurs. They're synovial joints, so you can get arthritis in those joints just like you can in your hip or your knee. Hand therapy and therapy can certainly help that. It's rare that we operate on those things because of the nature of the disease and the fact that it can improve with conservative treatment.
Great, thank you. Moving a little bit more into the diet side of things, with regards to probiotics, prebiotics, there's so many out there. How can somebody know which one is good for them? You did refer a little bit to this. Another specifically had a doctor mention recommending Metamucil and wondering if that type fiber would have the same benefits for gut health.
Yeah, no, it's such a common question, and as consumers, there's lots of different supplements out there, and so how do we know which ones work and which ones don't? And that's why the guidelines that I referred to there, so if you want to look that up afterwards, if you just go to that ISAPP, ISAPP, and go to that website, it's for clinicians, it's for consumers, and it has an entire list of all of the various supplements and food products. So I'll just put one example out there so it's meaningful. So in yogurts, Activia is a probiotic containing yogurt. So it lists all of them there, and it gives the scientific evidence for whether or not this product actually has evidence to manage a particular condition. And then you'll also see in there that it's not all conditions. So there's lots of them that are targeted towards different types of diarrhea, for example, or constipation. Some new ones are emerging that affect mood, so anxiety and very mild anxiety and depression. So it really is a very valuable guide for us as consumers to have some bit of reassurance to know whether or not this supplement could actually have a benefit. So I really encourage you to look at that if you're considering taking a probiotic supplement. And as far as prebiotics, we have less prebiotic supplements available to us as consumers compared to probiotics, which are really widespread and lots of them. But definitely the regular fiber supplements, so there was the mention of Metamucil. There's also a Benefiber, which is a actual prebiotic fiber. So there are, again, in the fiber section, the fiber supplement section is where you would normally find those supplements to assist. Yep.
Thank you. That sounds like great resources. I will pass it back to the room.
Oh, hi there. My name's Wayne Chang. I'm actually a primary care provider. I have two quick questions. I'm a true believer of exercise as medicine, and I agree it needs to be a proper dose. My question to my learned colleague from Dr. Whittaker from UBC is, how do I motivate my patients to exercise? Because I really struggle with that.
Yeah, it's a great question. And I think I would spin it around, and it's more, how do you get them to motivate themselves? So you have to figure out what it is that they're passionate about, that they want to do. Maybe something that they can no longer do that they used to do that's really important to who they are, and use that either as the carrot or use sort of a pre-version of that activity to slowly getting them more engaged in activities. So really, I think it's about identifying what's important to a person and working with them to do that thing, even if we don't agree that that thing might be the best thing. So, you know, for instance, maybe they're somebody who does an activity that you think, oh, I'm not sure that's really the best thing that you should be doing right now. If that's actually the thing that gets them started and starting to become more physically active and arranging their lifestyle to be more physically active, you can start there. If they start to have flare-ups and start to have problems, then you can have that conversation around, well, maybe we need to modify it or we need to do this a little bit differently. But they've already started to lay down a lot of the really positive habits they need to be physically active. So I think you got to figure out what really resonates with them and what's important to them.
Thank you. And for Dr. Reimer, I have a number of Asian patients in my practice, and are there examples of fermented food such as kimchi? Would that be considered a food rich in bacteria, of the good bacteria? And I want to know if there's a list somewhere where I could consult.
Yes, so absolutely, fermented foods, and we typically give an example of kimchi. I didn't know if this audience, some may know what kimchi is. It's a fermented cabbage from the Korean culture. The one thing with fermented foods is that they are best when they are not pasteurized. So there is some impact of the way those fermented foods, like sauerkraut, kimchi, some of the dairy drinks are okay because we don't typically pasteurize after we put those bacteria in. But yes, so getting more bacteria into just from the foods we eat is very important. And again, resource. And again, I have to direct you to that International Scientific Association of Probiotics and Prebiotics, so ISAP. It is just a phenomenal resource for all things related to probiotics, prebiotics, and fermented foods. And they have published a very, very good resource for us, a paper that talks about what are the fermented foods, which ones actually would give a health benefit to the individual when they consume them. So I would encourage anybody who's interested in, eating more fermented foods to look at that resource again. Because we used to get a lot more bacteria in the foods we ate, so we got just more bacterial exposure, which was a good thing. But we've, pasteurized, sterilized, processed, and we just really don't get the food bacteria load that we used to. So getting more of those traditionally fermented foods into our diet is very good for our happy gut.
My question is about vitamin D and bone health. I was part of a 3-year double-blind study on bone health and vitamin D with Dr. David Hanley. So is vitamin D currently considered important for bone health? What's the dosage? And should it be synthetic or from a food source, like, say, cod liver oil or something like that?
Doctors, who would like to handle this
Dr.
question?
I know Dr. Boyd.
Will we nominate Dr. Boyd, who's in the audience?
Dr. Boyd. Dr. Boyd needs a microphone. There we go. Okay.
I can just quickly comment because I was part of that study with Dr. Hanley, and ironically, we have the entire vitamin D study team. Right,
Oh, very nice.
So I'm not going to comment on the medical side of it. I'm going to be very careful about that because I am a biomedical engineer, and that's where Dr. Hanley really comes in. But I will say the message of that study, the major message of that study, was to take adequate vitamin D, follow the Osteoporosis Canada guidelines. Those are excellent. Taking more vitamin D, and what we were studying in that study was very high doses, doesn't seem to be beneficial, and to a small extent actually could be detrimental to bone. So taking enough is very important. So I'll leave that with that message.
And the synthetic versus the from a food source?
That sounds like a good question for Dr. Reimer.
Most of the vitamin D that you'll find available for us as consumers, that form is exactly fine for us to take. Yep. Yep.
You hit on cortisone shots. What's the benefit of it and what's the drawback?
Yeah, so I'll take that one. Really, cortisone is a potent anti-inflammatory medication. When it's injected into a joint, it doesn't have systemic side effects like taking a pill form. So the pill form is prednisone. People are on prednisone for various conditions. But when you inject it into the joint, it doesn't have negative side effects. When you take it systemically, it can affect blood sugars, can affect weight gain. It has lots of negative side effects, including osteoporosis. When you inject it into the joint, it just provides an anti-inflammatory effect that's very potent, but is very self-limited. It'll only last for 2 to 3 months, and usually that effect wears off. There's controversy over whether it causes harm to the joint itself, and I think that if you use it fewer than 3 to 4 times a year, you're unlikely to cause harm, but eventually the effect usually is limited and you have to go on to other treatments.
Another one from in-house, and Terry, just let me know if we've got some virtual questions as well.
Hi there, this is a question about knee surgery. Just wondering what the thoughts are on minimally invasive knee surgery where they don't cut, you know, the tendon and so on above the knee.
So there's lots of opportunity for continued research in changing how we do knee replacement surgery, but the reality is you still have to put a reliable implant in and get fixation to the bone for long-term success. A lot of the joints we put in today should last more than 20 years, and if it's cemented and in good position, it should last that long. The challenge is we always have this concept that something put in less invasively or through a smaller incision is better. The reality in implant surgery is you have to be able to put the implant in the correct position and not compromise that. So if the vision is compromised, if you're making compromises in how you do the procedure, there's other risks to that. And the main thing would be putting the implant in the wrong position, which impacts wear and then the longevity of that implant.
And just a quick follow-up, because I have 2 parents who've had a couple of replacements. It's really that post is so important, isn't it? There's the surgery, and I think sometimes people think that I know for my father, he just feels, oh, I can now just sit more. But he really can't. My mom is the complete opposite. She really got to her exercises. Could you just speak to the imperative, how important that is post-op?
Yeah, the post-op rehabilitation is critical, and it's often guided by physiotherapists and by the surgical team and nurses. It's really important that you follow those protocols, particularly in the first few months after a knee replacement surgery. We're also, through the Strategic Clinical Network, looking at prehabilitation, and a new program which we hope to receive funding and develop is to offer this province-wide to patients who are contemplating surgery to make sure that their range of motion, their strength is optimized, because there's good evidence that if you're well prepared for surgery, your outcome will be improved as well.
Oh, good. Excellent. Okay. We've got another one from back of the room.
Yeah, it's just for Dr. Reimer. Is there any kind of rule of thumb for how long it takes your microbiome to repair itself if you've been using, say, anti-inflammatories or other antibiotics for treating the pain or the inflammation and those sorts of things in the joint injuries?
So what we know about the microbiome is it can shift very rapidly. So there have been research studies where they drastically changed an individual, and this was with diet, and they could show that within 24 hours you can have a big turnover and a change in the composition, the profile of that individual. Now with antibiotics, there's 2 key areas of life. So if those antibiotics are taken very early in life, so in infancy, we see that the impact on that microbiome is much larger, and longer lasting. So that can have an impact many, many years into the future and can impact disease risk, so things like asthma. What they see with the microbiome in adulthood, when that microbiome has stabilized itself, so that occurs, right when we're around 3 years of age, it stabilizes and becomes more adult-like already. That impact of the antibiotics is less. It doesn't mean that for every individual they will come completely back to what their microbiome looked like before, but for many individuals, it will return. It could be weeks for it to return, sometimes months. But in adulthood, the impact of those antibiotics does seem to be quite a bit less than if those antibiotics are taken and experienced very early in life when that microbiome is trying to establish itself.
I have a question about exercise more in the community situation. Being a senior and without a car, and being told I should be swimming more. And what has there ever been thought of having a shuttle situation, for example, directly from seniors' places to recreation centers? Because obviously, if we have to stand out in the cold waiting for a bus, this is not helpful.
I'm not sure who should answer that. I think there's great logic in what you've just said. And I think that I looked at you just because of your position with the bone and joint SEN. I mean, I think that these suggestions are wonderful suggestions. And I think obviously living also in a province like Alberta where, it's challenging to go out for a few months out of the year. We all do it. We're all hardy. We can do it. But it would certainly be nice if we could access those first lines of care easier. I don't know.
Yeah, and I think through the strategic clinical network, we're trying to enhance those options regardless of where an Albertan lives. Mm-hmm. And one of the challenges, we live in a big city, but there are people living in remote and rural areas that also have even greater transportation challenges that we have to recognize should be part of the program. And so that's something definitely to work on.
Yeah. Okay, we're going to go back online. We still have a lot of questions coming in. So one, are we more prone to meniscal tears with age? And as a follow-up, maybe, are there any good options to help if you know your meniscus is worn away in the knees?
I can take that first question. If you look at, say, people over the age of 45, I think the statistics would suggest about 45% of those people have osteoarthritis. 30% of people over 45 years would have osteoarthritis of the knee visible if you did an X-ray. Only half of those people would be symptomatic. So I think the fact that osteoarthritis is more common as we age would increase your chance of meniscal tears. I think it's also important to know that not all meniscal tears are problematic. So I know someone who has a meniscal tear who it doesn't cause them any problems, and so they haven't had anything done to manage that. The second part might be better answered by Jason, I think.
You have to repeat it, sorry.
Yes,
I was so enthralled by your answer there.
So if the meniscus is worn away in the knee, what are some good options? And that may also go to Jackie for exercise pieces as well.
Yeah, I mean, there are some procedures in the very young who still have intact articular cartilage where they could have a transplant of the meniscus, but that's a very rare situation. In the vast majority of cases, when the meniscus is affected and it goes on and it's accompanied with osteoarthritis, then it's treated as part of the osteoarthritis treatment. When we do a knee replacement, we of course remove all of those diseased tissues, including some of the diseased cartilage and the menisci when we carry out the procedure.
And then another follow-up on that, maybe. I think it was Dr. Walker mentioned that arthroscopic debridement of OA in the knee is not really recommended anymore, and one of the viewers wondering why that's the case.
Yeah, there's many studies that have now shown that the risks of surgery don't, outweigh the benefits of surgery. And so a lot of patients may find symptomatic benefit or relief of pain for a short period of time, but within usually a year, they're back for another treatment, and usually that's a progression to a joint replacement. If a patient has intact articular cartilage and there's a mechanical or a catching in the knee, then occasionally an arthroscopy in the face of arthritis, depending on the patient's age, could be indicated. But we've really changed practice, and I've been in practice for 22 years. I've definitely noticed that arthroscopy used to be one of the treatments we offered to patients who were, reaching middle age and have symptoms. But a lot of those patients, in hindsight, came back for a joint replacement shortly after. And now our practice has changed, where we don't really offer it as part of the treatment protocol unless there's other factors like a very young age and mechanical symptoms, and we want to delay the joint replacement.
Otherwise known as the scope.
The scope.
The scope.
The scope.
Dr. Walker, did you want to follow up on that?
Well, one thing I was going to mention is I gave examples and around the guidelines that when MRI isn't typically indicated in someone with osteoarthritis, moderate to severe osteoarthritis. But if you think back to one of those images of the person that had severe medial compartment osteoarthritis, there are Dr. Werle's colleagues, and Jason might do it as well, that will just replace part of a knee, or so it's called a unicondylar implant. And in those situations, an MRI is absolutely indicated because you want to know what the cartilage is in the other compartment of the knee to make sure that that is healthy before you offer them a partial knee replacement. You also want to make sure that the anterior cruciate ligament is intact, which will be important for that surgery. And there's another surgical procedure that is sometimes done. It's called a high tibial osteotomy, where they'll take a wedge out of the tibia and redistribute the weight from the medial side of the knee to the lateral side of the knee. Obviously, again, you don't want to do that unless you know that lateral side is healthy. So there are reasons for doing knee MRI in patients with osteoarthritis, but in general, and as that one caption said, it is unlikely to be required in the setting of osteoarthritis.
Okay, thank you. I'm going to switch gears a little bit and move a little onto supplementation and joint health, perhaps a bit of a provocative one. Any thoughts or recent research around CBD oil as an effective anti-inflammatory?
Oh, don't look at me.
I'm looking at you.
Don't look at me.
So there are ongoing trials looking at whether it has some benefit. My understanding of the initial data is it's limited benefit, but more to come on that.
And then what about some other supplements? I mean, if you walk down the aisle in the grocery store, you're going to see a whole bunch of bone and joint health supplements, collagen, glucosamine, those sorts of things. Is there much evidence supporting those for being beneficial to joint health?
There's some large trials from the National Institute of Health out of the US that have looked at the use of chondroitin and glucosamine and came up with the results that really it's no better than placebo. There's some suggested benefit with chondroitin sulfate that it has a slight anti-inflammatory effect, but I think the research really doesn't support that. Now, does it do harm? It doesn't do harm other than to your pocketbook, so it doesn't interact with other medications. It's probably safe to take, but there probably is a placebo effect if you're taking it.
Maybe the real benefit comes from just getting up, walking to the grocery store,
Yes.
buying it, and then walking home.
Exercise, exercise, exercise.
So maybe it's okay if you walk to buy it.
Walk to buy it.
So on that note, then, one more from the online before we go back to the room. Around exercise, and I know dear to Jackie's heart, prevention of injury. So how can I prevent injuries while participating in sports? What stretches or exercises can strengthen the knee? And is there a use for things like neoprene braces to help either prevent or give some stability after injury?
Yeah, so I'll take the first one, injury prevention. There is an incredible amount of evidence out there to suggest that injury prevention programs, specifically sport injury prevention programs, that are typically administered as warm-up programs are incredibly effective in reducing the number of knee injuries that we see in young people. And there's great work happening here at the University of Alberta that's led by a colleague of ours, Dr. Caroline Emery, for years that has looked at this. And without a doubt, it's very effective. And depending on the sport you do, there's little differences in the nuances of the exercises you use. There's a great app, it's called Get Set, and it was put out by the IOC, and it summarizes sort of the key injury prevention type exercises for a variety of different sports, so that's a great resource. What was the second part of the question, Terry? It was bracing. Yeah, so bracing's an interesting thing. I'm certainly not aware of any evidence to suggest that if you wear a brace, you're less likely to hurt your knee. It's probably more of a conversation in ankles. Ankle braces are used a lot sort of prophylactically in jumping sports like volleyball, basketball, etc. And there really isn't great evidence to suggest one way or the other, and we will often say to the athlete, you do what feels most comfortable to you, and if you feel safer and you can move better and feel more confident with the brace on, then that's fine. There's certainly no evidence that they're bad, other than maybe they cost a little bit of money. As far as wearing a brace after you've injured your knee, I think it really depends on the injury we're talking about and the management. We've actually recently just done a very large, what we call a systematic review, where we go out and try to look at all the evidence out there on a particular topic and synthesize it. And in particular for ACL injuries, what we've seen is there's no effective benefit in using a brace after you've had an ACL injury. But don't tell that to somebody who's torn their ACL and maybe had it reconstructed and is now playing sports and actually feels a lot of benefit and have much more confidence in themselves moving with the brace on. So although there's no evidence to suggest the outcomes are better, that doesn't mean that there might not still be a place for it. So I think we still need to figure out what braces are doing and whether or not they're helpful. Some people find them very helpful, and like I said, if you synthesize all the evidence together, it would suggest they're probably not that helpful, and to go and spend $1,000, $2,000 on a brace, you know, it's a lot of cash for something that may or may not be effective.
Interesting. And that was Get Set, right?
Get Set.
Get Set
Yep.
app.
Yep.
Okay. I wrote that down.
Yep.
Yes. Okay. Yes. Right. Middle of. Yes. There we go.
Yeah.
Thank you.
Hi.
Yeah.
For osteoarthritis of large joints, is there any benefit in using platelet-rich plasma as an intra-articular injection?
Yeah, that's a really good question. There's a lot of people offering it. The science, I'd say, is not there to recommend it for osteoarthritis of the hip or the knee. There are some randomized trials in the benefit in soft tissues, such as rotator cuff of the shoulder. But even though it's offered as a treatment, really, probably most situations, it's a placebo effect that's having the benefit.
Hi. I must say it's amazing to have so much expertise in one room, and I want to thank everybody for being here today. I have two questions, perhaps 1,000 questions, but two I'll try to keep to. One is related to Dr. Whittaker. That is, you mentioned that exercise is good so long as the pain is less than 5 out of 10, I believe. Is there a potential for a feedback loop, however, that pain causes more inflammation, which then causes more pain, and so on? And is it better to have perhaps some sort of medication or even an NSAID of something to reduce that pain while exercising?
Yeah, so it's a fabulous question. And, you know, the way that we talk about pain with our patients isn't actually that it's a bad thing. It's your body communicating with you. And that's assuming that you don't have sort of a hypersensitivity in pain or we call a central sensitization with pain, where you actually can't rely on what it's telling you as much. But for most of us, our pain is actually a really important message. And so, you know, you can exercise, and, you know, 5's sort of an arbitrary number, isn't it? And it's going to be different for different people. But the message is, if you have pain, and it's not too much, and it's not limiting you too much, and you wouldn't probably rank it more as a 5 out of 10, if you do that exercise, and you don't go above a 5 out of 10, so that might mean you don't do it for quite as long as you wanted to, or as hard as you wanted to, and then you leave it, and then you come back to it again, and maybe you don't go as far as you want, and then you leave it. Over time, you're going to find your pain level's lower, and you're able to do more without pain. So the pain in that way is a really great way of your body communicating to you sort of where a threshold is that you don't want to go over. If you go over that threshold, you're absolutely right. You might start to see more inflammation in the joint, and you might start to have problems. But that in and of itself isn't necessarily always a problem either. That's you just figuring out, you remember I talked about trial and error. So the point is, some days you might do too much and you might kind of flare your knee up and it might get a little bit swollen. That's not great, but you learned from that and you learned where that threshold was. And so the next time you go out, you try to do less than that. And then you go, okay, yeah, well, that wasn't bad, and I can do a lot of that, but now I don't feel like I'm doing very much, so I need to do a little bit more. And you gotta play around till you find that threshold. And part of finding the threshold is you might go over it sometimes. And as long as you listen to your body when you go over it and you don't do, kind of push through it for, a huge amount of time, you're probably not gonna do a massive amount of damage or harm, but you are gonna figure out kind of what that fine line is. So I really talk about pain being an important message from your body and a guide for what you can do from an exercise intensity piece.
Thank you. Second question I had was for Dr. Reimer. Have you looked at types of bacteria that are very difficult to remove from the gut? And specifically bacteria that might be able to form a hyphal type of arrangement that invades the gut lining and is therefore very difficult to remove. And I'm thinking specifically something like yeast. And if that's the case, then this can cause an allergy. And I haven't heard anybody talking about allergies today, but it reverts back to diet, because if you initially develop allergies to certain foods, then it may be difficult to create a diet which is effective and according to the diet that you recommend. But have you done any research on that type of bacteria, and specifically the type of bacteria that can cause, a food craving, I guess you might call it?
Sugar at the end of that, yes.
Okay, so a couple things there. So the microbiome is actually composed of bacteria, virus, fungi, which includes that yeast. So it's all of these microorganisms together. And so far what the research understands the best is the bacterial component. There are some excellent researchers at the University of Calgary working on the yeast aspect, but that's very new. And some of their initial work is showing that some of these yeast might actually be related to, say, in infancy, causing allergies or asthma. So that's new, and we don't really understand how all of these different microbes or microorganisms live together in this community and how they interact and might affect each other. So that's what we're starting to understand about maybe some of these yeast. And then the other part was, are there some bacteria that are harder to get rid of? So there probably are. I can talk about some bacterial families are known to be very much associated with inflammation, so cause inflammation in the gut, which then can cause inflammation in other parts of the body. So again, there's no current understanding of how can we directly target them. You don't necessarily want to completely rid the body of them, because it's a community and you need this full community of microbes that we've seen to be healthy. So if you don't have, we call it diversity. So if you don't have diversity in that community of these microorganisms, that's when we often see disease arising in individuals. So yes, we would like to be able to get rid of some of those bad players, particularly the ones that are causing more inflammation, but I don't think the science is there yet to say this is what you need to do to knock those down. Yeah.
Now we're just closing in on 11:45, and so I know we'd love to keep chatting and asking lots of questions, but just in the interest of time, we'll just ask one more question if we could, and I guess we'll take that from the house.
Well, I'd like to thank you for the information. Today was wonderful. Maybe as a conclusion, in regarding my own personal knee injury, which was an ACL and an MCL tear while biking, at 67 years of age, my first sports injury, my daughter said. So I was quite positively impressed. But one thing that stunned me was the psychological impact. The fear of falling and going down a hill with debris as I continued to hike and do the things that I love was absolutely daunting. So if I join one of your, or hit on one of your websites, I would really like, I know it's a psychological aspect, but I would like it confirmed that I'm not going crazy, that when I couldn't sit down on a log and cried because I couldn't fold my leg under me, I was normal and it was a process.
Yeah, so
I have a comment on
well,
future things.
but I think we should validate your comment in the sense that what you're describing is incredibly common. And if you look at the ACL tear literature, and a lot of it is, 15 years to 25 years of age, young people playing sports, but yours is a very similar example. This lack of confidence is it's a key component to the way that this injury presents. And it's actually building that confidence back up and the self-efficacy to do activities that often stops people from being active. It isn't, people don't stop playing their sport necessarily because they can't physically do it, but they lack confidence or they're worried about re-injury. And so whether we talk about rehab, whether we talk about surgery, the follow-up to that has got to be working with people to move to build their confidence back. So you're not crazy. I think what the experience you had is very valid. What might be unique to it is just that you had it at an age where maybe it isn't discussed as much because people don't tear their ACLs a ton when they're over 30 years of age, but it certainly happens. I have a good colleague who tore her ACL skiing just a couple years ago in her 50s. So what you're experiencing is very valid. And I do think that if you look at a lot of the ACL rehab and the ACL literature, you will see that this psychological piece around confidence is very, very prominent.
Thank you for that question. Thank you, Dr. Whittaker. Thank you to all of our panel of experts. I think a huge round of applause. They say that knowledge is power, and I certainly myself, I feel truly grateful because I feel really empowered with all the knowledge that you have provided with us today. So on behalf of those of us here and those of us at home, thank you again so much, and thank you especially to Dr. Donna Wood and your family for the Wood Joint Research Fund to keep these programs going and to allow us to have these truly impactful public events that connect us to these incredible minds, these incredible healthcare professionals. So thank you again. Now, if you enjoyed this event and would like to see more content from us, please stay in touch with us on social media. There we go. We're on Twitter, Facebook, and Instagram. And as Dr. Werle mentioned earlier in our program, feedback is so incredibly important. You will receive an online survey in the next few days about this event for our evaluation purposes, so we can go forward and continue to expand and improve. Please take the time to complete it. It will really help us to make the best decisions for this event in the future. And also, if you haven't already, we invite you to visit our community partners at their information booths that are up in the lobby area. That includes the formal part of our Wood Forum program. Thank you so much for coming. Please mark your calendars and join us next fall for the Wood Forum 2023 Healthy Bones for Life. Subscribe to the McCaig newsletter by scanning the QR code on screen and be among the first to hear our finalized 2023 date. Thank you so much. Enjoy the rest of your weekend, and might you consider, on behalf of Dr. Reimer, a fiber-rich lunch. Thank you so much. Have a great day.